Okay, so this patient, after a motor vehicle accident with lightheadedness. Okay, sorry, like I just got stopped. Okay, so let's put your orders. He's in the ER. So what do you want to do for someone with a trauma? What do you do?
Fast.
Fast. Okay. Cervical spine immobilization.
Mm-hmm.
That's for anyone with a trauma. Okay, and then we do pulse ox, oxygen, the police.
Mm-hmm.
Okay, IV access, IV fluid. What else do you want to do?
Um,
Cardiac,
Cardiac monitor, BP monitor, EKG.
EKG. Finger stick glucose. Do you want to do toxicology maybe? Just in case?
Toxology, sure. We can do a blood alcohol on him. We can do a urine tox.
Yeah. Okay. So what do you want to do now?
Um, we did an EKG. Can we get an EKG result, please?
Let's examine him, and while the
Oh yeah,
EKG will show
yeah.
up on the same time.
Yes, exactly. I forgot to examine him. Right.
Okay, so when you examine him, he's well built, white male, severe pain, holding in his chest, holding his chest with his right hand. Lung is clear. Cardiovascular shows bradycardia, variable intensity of S1, no murmur. Okay, you got the EKG. EKG shows complete heart block, ventricular escape rhythm, rate of 40, QRS duration of 140 millisecond. No evidence of ischemia or injury except non-specific ST wave changes. Okay, let's order chest X-ray. Damn, how did I forget
I,
that? Yeah.
yeah, chest
No,
X-ray.
let's get the other stuff. Let's do chest X-ray.
Did we do CPC, CMP?
Yeah,
We did UA, TSH, lipid,
serum
ESR.
lipid, GSR, OPT, maybe amylase. Do you want to do anything else?
Um,
Yeah, that should be fine for now.
so basically this guy's EKG came out yet or no?
Yeah, I told you there is a complete heart block on the EKG.
So we need to put him on a pacemaker.
Yeah, and the chest X-ray came back. It's left fracture on the left third and fourth rib, but no pneumothorax.
Okay, so we're gonna give him a lot of pain meds.
Yeah, let's give him morphine, and let's do a neck X-ray too. Could be in spine fracture. Cervical spine X-ray. That's what I want to do. Morphine. What else? What do you want to do? Anything else?
Morphine.
Let's
I
give
don't
him
know.
atropine.
Why? For a tertiary block, that's not going to do anything.
Hmm?
Atropine works until second block, second degree type block.
Yeah. So you want to do transcutaneous pacemaker?
Yes.
Hmm?
Yes.
Okay, let's consult cardio too. Let's bring him on board. Let's consult orthopedic. Put him on NPR. Let's do PT, PTT, just in case they want.
Mm-hmm.
Continuous IV. Cervical, spine. Consult orthopedic. Would you do orthopedic residency?
No.
Yeah, it's terrible, right?
No. I
Yeah,
would only do family or ER. That's it. I
yeah,
don't even like anything else.
yeah. It's annoying. Like feels like it's different. It's totally different. Okay, so now what do you want to do?
um.
So let's get the results, right? And let's admit him.
Yeah.
Yeah, it's hard to block and stuff. Let's just put him admitting orders and then we'll vitals, amatosophy, panic, rest, panic, decompression. Let's just get our results. So
Yeah.
now, yeah, now after the transcutaneous pacer, his heart rate is 80, and his lightheadedness and chest pain is better.
Good. What is 80?
His heart rate.
Oh, good. So you gave him pacemaker?
Yeah.
Good.
The labs are fine. Hematocrit, hemoglobin, everything is fine. Becker.
Good. I'm so sorry. I kind of got distracted. The fast results said what? Negative?
There's a fracture on the ribs. Everything else is
Besides
negative.
that, there's
It's
no
negative.
bleed.
No
Nothing.
bleeding. No bleeding. No.
We cannot do, as long as there's no puncture of the lungs like pneumothorax from that, that should be fine. We'll just have to. Did you see air entry was equal on both sides? There was no flail chest,
Yeah,
right?
it was equal, and the chest X-ray excluded pneumothorax too.
Okay, good. No flail chest. Sometimes the rib fractures cause flail chest.
Yeah, only two sides. Yeah, there's no flat test.
Yeah,
So
yeah.
didn't mention any flat test.
Mm-hmm.
Okay. So now what do you want to do?
We admitted him. We'll have to keep him for a few days.
Let's advance it for 2 hours and examine him again.
Yeah, let's do that.
Let's just check heart, lung, turbo follow-up. Well, now his pink conjunctiva is is fine, abdomen is fine, heart is fine, extremity is okay. Yeah, everything seems fine right now. Okay, so just continue. Let's see the order. Continue BP monitoring, heart monitoring, normal saline. Let's continue. Let's do it because it's a traumatic accident. So let's do creatine kinase. Okay, let's do cardiac enzyme troponin. Let's do echo. Let's get the results of those, and we're monitoring him anyway. Okay, so now the CK is 500, troponin T is 0.5, echo shows ejection fraction of 55. No all abnormalities, all valves are normal, no pericardial effusion. Cardiologists take the patient to the cardiac cath for temporary transvenous pacemaker insertion. Okay. If the case continue further, maybe we need permanent transvenous pacemaker. Okay, let's just follow him up. He's better, stabilized, so that's a really good thing. Yay! High five! We did it.
Yay!
Yay! He's feeling better. You know, it's like it feels better. It's a software, like it simulates patient, but it feels better. Imagine if it's a real patient, like it's a beautiful field. Yeah, okay. When you get to take care of people. Okay, so that's now once he's feeling better, you can discharge him. Schedule a follow-up.
Yeah, I take this software like a video game. Like I enjoy it.
Yeah, that's true. Me too.
It's amazing. Whoever built it is so amazing.
Yeah, it's really. And step 3 is the best exam out of all of them. Like make you a real doctor. Yeah. So what's the most important cause of hypertension in a trauma patient?
What is the most common cause of hypertension in a trauma patient?
Hypotension. Yeah.
Oh, hypo, bleeding.
Yeah, it's hemorrhage. So the first thing, IV fluid and do CBC to control those. Okay, and then you do imaging, the FAST, which is great for pneumothorax, intra-abdominal hemorrhage. Okay, if the bradycardia with hypotension and normal hemoglobin, what raise your suspicion?
So you can have hypotension, bradycardia, and Cushing's reflex due to increased intracranial pressure.
Or heart abnormalities.
Or heart. I mean, we already did a heart case because of the cardiac block, but then another scenario would be ICP, right?
Yeah, you're right. Yeah, that's a good thought. Yeah, this is a very good thought. Yeah, so this patient, so if there's tachycardia with hypotension, then you suspect hemorrhage, right? But if tachycardia with hypotension, either Cushing or heart block, okay? So you do EKG, the EKG confirmed the 3rd-degree heart block.
Yes.
Which made by IV dissociation, slow ventricular escape, 40 beats per minute. Okay? And the P wave has no relationship with the QRS. Okay.
So, So wait a second. Let's go over the EKG. The EKG is the PR interval has no relation to the QRS, right?
Yeah. Yeah. So now, what are the causes of 3rd-degree heart block?
The causes could be syphilis.
Yeah, it could be also medication like beta blocker, calcium channel blocker, digitalis.
Medication.
Yeah,
or
amiodarone.
Why did this guy have a 3rd-degree block?
Why
did he have a 3rd-degree heart block?
Yeah, it could be a trauma, it could be ischemia. Yeah. So because of the trauma, that can happen. Can happen many. So these are the first thing you look for reversible causes. So if he's taking any of these medications, then you stop them and keep monitoring him. Stop amiodarone, stop digitalis, stop calcium, channel blocker, beta blocker. It could be hyperkalemia, you correct that. It could be valvular abnormality, it could be cardiac abnormality, it could be sarcoid, it could be hypertrophic cardiomyopathy. So if any reversible, if you can fix it, fix it. If not, then you just add, so you put temporary pacemaker and then look for these abnormalities to fix them. If you didn't find any, then what do? Then you convert him to permanent pacemaker.
Oh.
Okay?
Mm-hmm.
So why this patient had elevated creatinine kinase and troponin T?
Oh, because of injury.
Yeah,
Muscle injury.
what do we call that?
Myoglobin, rhabdomyolysis?
No, it's called myocardial contusion.
Oh, wait, I'm sorry. What are you asking? You said creatinine kinase or CKMB?
Yeah, CKMB, creatine kinase MB. And troponin T. Elevated due to myocardial contusion.
Oh, because troponin I is elevated in an MI.
Yeah. Yeah. So the only modality of treatment for complete heart block is pacing.
Yes.
Atropine can only, of a little benefit, might sometimes transiently
See?
improve heart rate and blood pressure. So you may give it, but it's not that important. The main thing is the pacemaker.
Yeah, exactly. Like I told you, because atropine only works until heart in the second heart block up until type 1. Even type 2 needs a pacemaker. It only works until type 1.
Yeah, and even this life packs that they have, it's equipped with a pacemaker to regulate the heart, because this is important. It's like it's a bridge for transvenous pacemaker. This transcutaneous, this is like temporary.
Yeah.
Okay, how about if the heart block persisted for next couple of days? What's treatment for that?
Heart transplant. I don't know.
Permanent pacemaker.
Permanent pacemaker, yeah.
How about
But
if the patient has second degree AV block who are asymptomatic or hemodynamically stable?
I think I'd leave it alone.
Yeah, maybe
So,
you can manage it without pacemaker.
yeah, with atropine.
Yeah. How about complete heart block but no symptoms? What do?
Oh, you would still pace them, I think.
Perfect, smart. You still pace them because you don't know when the patient gonna die.
Mm,
So another important thing, you gotta avoid medication that causes bradycardia.
absolutely, like beta blockers.
Yeah.
Anything that dilates your vessels, like calcium channels or any vasodilators, because that's gonna lower your heart rate.
Yeah. Yeah, and there is one important thing, like if someone who's hemodynamically unstable, you try to avoid morphine and give them ketorolac and fentanyl to control these
Why?
patients, huh?
Why?
Because morphine worsens the hemodynamic parameters. Like,
It does?
yeah, it slows the heart rate, it slows the blood vessels, slows everything down, and
Mm,
that's not good.
mm.
Okay. So in summary, this heart block caused by what in this patient?
Trauma?
Myocardial contusion. Yeah, good job. Yeah, myocardial contusion causes heart block here.
Mm-hmm.
So that's the cause for this.
Mm-hmm.
So how would you summarize this really quick, like in simple terms?
A patient who has a trauma, the first thing we need to do if they're unstable is fast. Fast will tell you there's a bleed or no bleed, which is the cause of the hypotension, and EKG. EKG told us in this case that he had a complete heart block. We know that once you see that, you're supposed to temporarily pace the patient, which is what we did in our case, and we monitor. and that should bring the rhythm back into normal, like him, you know, and we should just monitor basically, right? That's
Yeah,
it.
yeah, you're right. Yeah,
Mhm.
that's about it. So
Mhm.
do you want to do another case?
Do you mind?
Yeah, we can do another case.
We can do a short case, like a 10 minute.
Yeah, yeah, but these are very important cases and not too much, so we just wanna monitor them
Yes.
really. Okay, so let's go to this one. Okay, so this patient presents with generalized body ache and weakness. You did vitals is blood pressure.
Mo, I cannot. You were too fast. Sorry. I'm not. What did you say?
So let me see. Let me just upload that. What's happening? Okay, let's do this case. Okay, so now this patient is an 80-year-old male who presents with body aches and weakness. Okay, can you hear me?
Mm. Yes.
Yeah, vitals, blood pressure is 100/60, heart rate is 100, respiratory rate is 30, temperature is 100. Okay,
Mm.
let's go to the HPI. I like these cases. So when you are an 80-year-old male and you've been found lying on the woods on a hot sunny day, okay? So this guy who was found on a hot sunny day, it seemed that the patient had gone for a stroll last evening and fell down. He was unable to get up and shouted for help but could not get any. He had been lying on the ground for the last 24 hours until his son found him. The patient complained of severe body aches. He's very weak and thirsty. He denied lost consciousness, did not pass urine for the past 24 hours. No history of head injury or seizure. He has no allergies, not taking any medication. The patient does not smoke and deny alcohol use. Family history is non-contributory. Review of system is fine. So how do you approach this patient?
Okay. First of all, I'm going to start an IV access. Give him oxygen. Check his pulse ox. Give him fluids. Do an EKG. Do a urine analysis.
What does this generalized body ache indicate for you?
Rhabdomyolysis.
Yeah, that's an important. So it could be muscle injury. Sure. So we need to do thorough physical just to see.
Yeah.
Could be
It-
anything causing this issue. So
yeah.
let's do the things that you wanted. Okay.
And
So
glucose, of
pulse,
course.
pulse
Pulse
ox,
ox, oxygen,
oxygen. So
IV
police.
access,
Yeah,
IV
IV
access,
access, IV fluid,
normal saline. Um,
cardiac monitor, BP monitor. Okay. So
urine analysis,
police, PS,
EKG,
finger,
finger stick,
glucose.
EKG, and UA, like right now. Yeah. I want to see this myoglobin.
This is okay. CBC,
Did UA twice, but it's okay.
CMP. Okay.
Mhm.
Mm. Okay, let's do a physical exam. Well,
Even though he said he didn't lose his consciousness and he didn't hit his head, should we do a CAT scan on in an elderly patient? Head CT?
you can, but it's not necessary.
Well,
Yeah.
because it's subjective. Like I mean, he could have like subdural hematoma or something. I don't know. I'm just saying.
Yeah, you're right. Could be. Yeah. Well, we can order it. Not an issue. But let's see. Maybe we can find the cause right now. So now the physical
Can
examination.
you do rectal too? Like, I want you to do rectal because I want to make sure like he like do
Do you want to
everything.
do genitalia?
Yeah, why not? He's an old
You
guy
want
who
to do
knows.
breast?
He doesn't have. I mean, he has it, but like,
He
you know
has
what
a
I mean.
small one, you know.
Yeah. Okay.
Yeah, so the physical, he's respiratory is clear on auscultation, heart tachycardic, abdomen is fine, non-tender, no organomegaly, extremities is fine, neurological is awake, alert, oriented, no focal neurologic deficit. So that's about it for this patient.
That's it. Okay.
Yeah, so it's almost normal.
Good.
Okay, so now what do you want to do?
His neuro was fine. Cranial nerves intact.
Yeah, no focal
Okay.
neurologic deficit. So what do you want to do? Let's get some of the results.
Yeah, because I don't know what's going on. I want urine analysis and I want EKG. Because he could just pass out with a heart block too.
Yeah. So now the BU1 is 45, sodium is 134, it's fine. Like hemoglobin 13, white BC is 13,000. That's a little bit off. And then the urine dipstick is positive for blood, and urine microscopy no RBC or white BC. Reddish, gold pigmented cast.
So is it rhabdo?
Yeah, that's what it looks like. So how do we confirm
You
that?
don't find, because you don't find RBCs in urine.
Yeah, but there's reddish gold pigmented
Yes.
cast. Yeah, that's.
You will see red urine without RBCs.
Yeah, so this looks like rhabdo. So what do you wanna do? What should we do right now?
And his creatinine should be like a renal, you know what, like when there is pre-renal, post-renal. This is like a renal injury.
Yeah, so let's do CPK, calcium, magnesium, phosphorus,
Mm-hmm. This
uric
is a very
acid.
good
Huh?
case. I have done a rhabdo case.
Yeah, myoglobin. We can
Mm-hmm.
do
Mm-hmm.
urine myoglobin, and then do PT, PTT, INR, lipid profile, ESR.
How do you treat rhabdo? You just give them IV fluids, right?
Supportive, yeah, supportive, yeah. Let's do abdominal X-ray. It's not important, but you can do that. What else do you want to do? CBC. Let's do CBC every day. CMP. Let's do it daily. CBC, CMP. Let's do. Do you want to do cardiac enzymes? There's no need for them, but that's okay. What else? What do you want to do?
Mm-hmm. Mm-hmm.
Let's do TSH. Yeah, I think that should be enough for now. Let's do CPK serum. Myoglobin, we can do urine. It's fine.
Mm-hmm.
So now the CPK 10,000. I know it's calcium 0.9, magnesium is
Mm-hmm.
1.8, phosphorus a little bit high, 5.5, uric acid is high,
Mm-hmm.
myoglobin is positive, urine myoglobin, PTT is normal, PTT. So it's a typical case.
So he has acute kidney injury.
Yeah.
Are we gonna admit him to floor
Yeah,
and do
yeah. That's what
out?
I would want to admit him. Yeah. He's an 80 years old guy.
Mm,
So let's do vitals. What
P
else? Mm.
P for
Do you need to do
yeah.
omeprazole here or?
No, we don't need to.
Yeah, so
Mm-mm.
there's no. So it's V panic, okay? Bed rest. Panic is the omeprazole. So give them bed rest activity. B panic.
We don't
NPO.
have to keep him and why are you keeping him NPO?
Yeah, yeah, diet. Yeah, put him
Give him
diet.
good diet,
So panic. ANI input.
input output, which is important because he
Yeah,
has been so long.
pneumatic
Yes,
compression.
definitely. And yeah,
Diet. Just give him normal diet for now. So let's do something. I wanna check his urine pH
for what?
for the myoglobin.
What is it supposed to be?
Because like when you have a consistent damage to the kidney, it causes. So this when you have a myoglobin damages the kidneys, it causes acute renal injury.
Hmm.
So you want to monitor the pH of the urine. It doesn't matter. Like it's just a routine. Okay, let's put the CPK. Let's put it every 4 hours and the BMP every 4 hours and magnesium and sulfate every 4 hours in this case.
Hmm.
What else? What do you want to give him? Let's give him mannitol. You want to give him mannitol?
For what? He has intracranial pressure? Or mannitol for what? Diuresis? No.
Yeah. So this mannitol and bicarbonate we give it only if the urine pH more than 6.5 or the urine output more than 300.
You're right, but he's already deprived of fluids.
Yeah. No, but we gave him fluid. So after we give him fluid, let's consider the urine output more than 300 and let's give him mannitol.
Okay. What is mannitol gonna do?
So mannitol is like an osmotic. So it attracts the fluid into the circulation.
Ah, gotcha.
So
Is it if I
CPK
don't
every 4 hours, huh?
so if I forget to order mannitol, I'm gonna lose this case?
No, no.
Oh.
Only if the urine output more than 300, it's not important, most likely supportive. But here you want to monitor magnesium, phosphorus every 4 hours.
Yes, because of muscle injury.
Yeah. Let's just check him out every 3 4 hours.
Now what do we do?
Now let's just check him out, see how's he feeling. We don't need to do all of that. Okay, boom, now he's feeling better. Okay, so since he's feeling better, that's what I would
We
want
can
to do. Just discontinue the mannitol, there's no need for it. Bicarbonate, he's feeling better.
so you can take
Let's
his
let's 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 stop the IV fluid. Where is it?
yeah.
And let's order half normal saline. Okay. This one we can order 0.45 saline.
Why?
What happened? Yeah, because not too much fluid. Like we just give him half normal saline.
Okay.
Yeah, this we can because we don't want to overload him with the fluid.
Mm-hmm.
No, just monitor him. We did everything. That's what I know.
Yeah. After we do our session, I do the cases on my own, the ones that we just did.
Oh, like what do you mean?
I do it. Like right now, you're doing it,
Yeah,
then I do it.
that's good. Yeah. So you do it in the software,
Mm-hmm.
but some of the cases are not is not in the software.
Yeah, but then it's in the. Oh yeah, you're right. But the most of them we did were there.
Oh yeah.
Yeah, I mean, I didn't come across that wasn't there, but maybe the one we did today wasn't there. Yeah.
No.
The hard, maybe.
Okay. So now how? That's about it. To be honest with you, there's not much to do. So what is it? Do you want to do anything else?
No,
Yeah, that's a very good case. It's
I like this case. I haven't done it.
yeah. So what do you want to do right now? What do you could you summarize the case for me?
Yes. So here we had an elderly who passed out, who fell, and God knows what happened to him. So what we need to do is we need to rule out um three things: head injury, cardiac problem, and renal. We have to check out like what happened to him. So we're gonna order like chest X-ray or head CT to rule out anything, or even urinalysis to make sure like he's not peeing blood, and we get our differentials from there. Once we get that, we manage him supportively, bring up his blood pressure by giving him IV fluids, monitor his BP, and monitor his urine and monitor his myoglobin and CK and make sure everything comes down, after we manage him, basically. And yeah, just follow up and then admit him and then keep monitoring him until he gets better, his input output, to make sure his fluids are good. Once his urine output is more than 300 ml, you can start mannitol, and then that's it, right? Is there anything else I'm missing?
Yeah, you're right. Yeah. So this patient is rhabdomyolysis, maybe because of prolonged immobilization or
Mm-hmm.
compression of the muscle lead to ischemia.
Mm.
Okay. The hot climate change and dehydration uh, contributed to the myoglobin-induced renal necrosis.
Mm.
Okay. So there are two causes of myoglobinuria or rhabdomyolysis. Could be traumatic, crush injury, burn, and could throw electricity or something. And there's non-traumatic, which is muscle hyperactivity, like strenuous physical activity, seizure, delirium. Could be muscle compression, prolonged immobilization, coma, like this guy that we have. And could be muscle ischemia, acute
Mm.
arterial occlusion. Could be malignant hyperthermia, neuroptic malignant syndrome, hypothermia. Could be viral, HIV, bacterial. Could be drug, alcohol, heroin, cocaine, amphetamine,
Mhm.
zidovudin, statin. Could be causing this. Could be metabolic disorder like hypocalcemia, hypokalemia, hypophosphatemia, hypothyroidism, hyperthyroidism.
Yes.
It could be metabolic myopathy like carnitine palmitoyltransferase.
Oh my
Confusing.
God.
Yeah. Yeah. It could be carbon
Quarantine,
monoxide, snake bite.
quarantine transfers. Wow.
Yeah.
Okay.
Yeah. So that's the thing. So the diagnosis most common complaint is muscle pain, which is very non-specific. Okay. So any comatose patient with dark brown urine and muscle pain, you suspect rhabdomyolysis right away.
Mm.
Okay, this is because the myoglobin urine causes the urine dipstick to falsely be
Yes.
positive. Okay, so this is
Yes.
because this is the 2 minute screen. Let's order. What do you want to do? Let's do order colonoscopy
We're
because
gonna do a colonoscopy on him. We're
yeah,
gonna do influenza vaccine.
mama.
We're
No, no,
gonna
not mama. He doesn't have mama.
hmm?
Well,
Oh
he doesn't have mama. I was about to do mama.
no,
DEXA scan and what else?
influenza vaccine.
Yeah, there's a vaccine and pneumococcal.
Um.
Just put it later.
Yeah, I think I'm gonna do a AAA screen on him.
That's a good idea.
I don't know if he was a smoker or not. I don't know.
That's a
Oh
good.
no.
That's very smart. Yeah, USP STF recommend people from 65 to 75 recommend screening AAA.
Oh, it's 65 to 75. Okay, then this guy doesn't fall under
Yeah.
criteria.
Yeah.
But I always order AAA screen on all men who smoke on if they're above 65.
Yeah, but I think it's till 75. Yeah, but you can order that anyway. AAA ultrasound, you mean? I've done an ultrasound. That's what you want to do?
Mm-hmm.
Let's see, he's smoker or anything. They didn't tell us. They just counsel him on some stuff.
You didn't say anything about that, his personal habits.
So what do you want? Does it counsel on alcohol? What else?
Is there a difference if you say counsel alcohol or if you say no alcohol?
Yeah, there's different. Like some people tell them no alcohol. Like someone taking metronidazole, no alcohol. Or someone have
Oh,
hepatic injury, no alcohol.
because I never write counsel alcohol or counsel smoking. I always say no smoking, no alcohol, no drugs.
Yeah, I don't think it's that much a bigger of a difference, but they say it's when you don't want them to drink alcohol at all, then you know alcohol, like someone liver damage or something like that, or pregnant. But if someone who's like normal, he can't tolerate alcohol, you
I
just limit
never.
alcohol, huh?
Mm,
So that's the
so I
difference.
should say counsel alcohol. I should practice saying that then because I always say no because that's what I type. I type no
Yeah,
alcohol, smoking, no drugs.
yeah. So that's still fine. Yeah. So yeah. So this patient. So the most. So this when you have a urine and dipstick and the plasma creatinine concentration rises more rapidly with rhabdomyolysis than any other cause of renal failure.
Mm-hmm.
So it's usually more than 2.5 per day. So it's rise significantly. So the key for that is just to measure the CPK, which raises 2 to 12 hours after the injury and reaches peak value in 1 to 3 days after injury. And the peak and it ranges from several hundred to over 200,000. Okay. So what if the serum CPK remain elevated despite treatment? What do you think is going on?
If CPK levels remain elevated despite treatment,
This most
then I'm
likely could be ongoing muscle injury and could be compartment syndrome. So examine him again and stuff like that.
okay.
So if the myoglobin is also released from an injured muscle, it increases before CPK and decreases more rapidly because of the clearance by kidney and metabolism to bilirubin. Okay, so that's why the normal serum myoglobin and absence of myoglobinuria does not exclude diagnosis of rhabdomyolysis. So that's an important because myoglobin can be easily excreted by the kidney or converted to bilirubin. So if you have normal myoglobin, that doesn't mean it's not rhabdomyolysis. Okay. So that's why so what are the electrolyte abnormalities associated with rhabdomyolysis and why does that happen?
Electrolyte abnormality with rhabdomyolysis. Um,
Due to
hypo.
influx from extracellular compartment into the muscle, like water and sodium and chloride, all of them will be decreased. So we'll have hypovolemic shock and hypocalcemia, calcium even, go to the muscle. Okay. And the other one, efflux from the injured muscle into the compartment, like potassium goes outside, uric acid, phosphate, all of them, lactic acid goes outside. So that's why you will see
Muscle breakthrough, yeah.
you see hyperkalemia, hyperuricemia, hyperphosphatemia, metabolic acidosis. And myoglobin goes to the tissue, goes myoglobinuria, nephrotoxicity. And you can even have DIC. Creatine kinase will be elevated too, increased creatine into urea ratio. Okay, so the management is based on two components for management for myoglobinuria. What are they?
It's just fluid resuscitation.
Number one is the fluid. This is the mainstay of treatment, just to prevent or limit acute tubular necrosis. Okay, and many electrolyte abnormalities precipitate rhabdomyolysis, and the syndrome itself can lead to various metabolic derangement. That's why you need to monitor BMP electrolyte very closely for initial 2 hours. You're going to monitor them very closely. This is very important. You give them fluid. That's number one. What is the second thing?
I'm not sure.
So they say first, alkaline diuresis using mannitol and bicarbonate is recommended by some, because alkalinization of the urine, how's that going to help us?
That means there is bicarb and acid, something to do with bicarbonate acid, right?
It's to prevent precipitation of myoglobin in the tubules.
Oh yeah.
Okay, and this patient used only if the blood pressure is stable and the urine output established using isotonic saline. Okay?
Mm-hmm.
And you gotta be careful for the large volume overload, because he can be fluid overloaded.
Mm-hmm.
Okay, so that's the case of rhabdomyolysis due to immobilization. Okay, so let's do a rapid review of what we did for today.
Yeah.
So we had this case when you are immobilized and having rhabdomyolysis. Then the first thing I'll do the police BS, and then I'll order CPK, myoglobin, urea every 4 hours or so. And then I'll admit you to the hospital. I do V-panic, and then I'll add mannitol and serum bicarbonate with the IV fluid, everything, and just monitor. That's an important. That's what they love. Monitor CPK, magnesium, BMP every 6 hours or so, every 4 hours. Okay.
Mm-hmm.
That's about it for this patient. Now, if you have a lightheadedness after a motor vehicle accident, the first thing I would do, you come to the emergency room, I'll do the police BS. Okay, and then I found with the EKG heart block, so I'll give you transcutaneous pacemaker, and I'll look for reversible risk factors. If none of the reversible risk factor found, I'll give you temporary transvenous pacemaker after transcutaneous, and then I'll look for risk factors. If I can stop medication or treat any of them, then that's good. If not, then I'll just switch you to permanent pacemaker. Okay, and then admit you to the hospital. I'll do V-panic, and then so the first police PR, police BS, and then we ordered the mnemonics called CBC, LFT, ICU packs, which basically involve. You know that mnemonic? Do you know that?
Yeah, I have my own.
Yeah. This is similar to Cataglin, but it has more stuff.
Yeah.
Yeah, sometimes. I think you know it. Yeah. So you can do that, and then you admit him. You do V-panic, consult cardio, continue NPO, CKMB, troponin. When you have troponin is high, the cardio taken to catheterization. Yeah, and that's about it. The main, the rhabdomyolysis case, if I want to summarize it in 2 words, IV fluid and mannitol. This one, heart to block, if I want to summarize it in 2 words, I would say transcutaneous pacemaker and atropine. That's it. Everything else is routine. Okay, now if patient who have a lower.
Sorry, Mo, did we give him atropine?
Yeah, you can give him. It's a little benefit. It's not that important.
Oh.
Yeah. But it doesn't, like, you can, if you give him atropine, that doesn't mean that you can't give him transcutaneous pacemaker.
Oh.
Yeah, it's controversial. Some of them say that it's important. Some of them say it doesn't help. Yeah. So now with a lower GI bleed, when you have a lower GI bleed, so what should I do for you? The first thing I will do the police BS, and then I will order the CBC LFT ICU packs, and then I'll admit you. And then once I found the result, I found the hemoglobin is less than 7, and I'll give you a transfusion of the RBC. And then I'll admit you to the ICU. I'll do V-panic, and then monitor your hemoglobin every 6 hours. And then after you stabilize, I'll give you a polyethylene glycol and colonoscopy. Just reassure and counsel, and that's it. Okay. Now, if you have a black colored stool or upper GI bleed, like with a, So the first thing in the ER orders, I'll do the police BS, and then I'll order CBC, LFT, ICU, PACS. And then I found the result, I found the hemoglobin low, I'll give you blood transfusions. And then I admit you to the inpatient, I'll give you V-panic, and then monitor hemoglobin hematocrit every 6 hours. That's both in lower and upper GI bleeding. Okay. And then once you're stabilized, I'll stop the NPO IV fluid and just monitor hemoglobin. I'll give you IV ventiprazole, and then counsel you, and that's you're good to go. Leave you, discharge you on PO on pressor. Okay, and that's the end of today's discussion. It was very fruitful, good discussion. Okay, so I will see you tomorrow then.
Thank you.